Hi everyone, we're going to do some more focus. We're going to start with the actual cases. I would suggest if you haven't reviewed the normal echo and the didactic on the RV function that you go back and look at those before you start doing some of these cases with me. The first case that we'll be doing today is a patient who came in with significant stridor who required an urgent laser to vocal cords. I can't remember exactly what the pathology was, but basically the patient was going to be requiring jet ventilation. The previous medical history available to us, but the patient had pulmonary hypertension and emphysema and currently in severe stridor. And I do give some credit to Dr. Morizani, who was our POCUS fellow at the time, for the excellent images that she obtained in the holding area before the patient went into the OR to give the anesthesiologist a little bit more information on what they were going to be dealing with intraoperatively. So our first image is the subcostal. So I'm going to let you just have a look at that a little bit, see what you think. So remember that we have our left atrium, our right atrium, right ventricle, and left ventricle. I want you to think a little bit about your comparative sizes of what the right ventricle should be compared to the left ventricle. And also, with the history of pulmonary hypertension, think a little bit about the RV function and see what you think. From my perception here, what really stands out is the increase in size here on the right. Both the RA and the RV are what I would say severely dilated, and there is some LA dilatation as well. This LA is definitely more than half of the LV. We might be foreshortening the LV, so we can recheck that in the apical views later. You can't do color really with POCUS. It's not something that we teach at this level, but you can look at the valve leaflets and see if they're co-opting to get a sense of whether there would be some tricuspid recurge. So really at this image, again, what stands out for me is the increase in size on the right side and some decrease, I would say, function on that right base. There's a free wall that seems to be functioning quite well. So to get another sense of that right-sided pressure, we can look at the IVC. So the IVC gives us an idea of really the load in the RV, which can be an assumption on volume status, but in a patient with significant tricuspid recurge or right ventricular dysfunction, not necessarily fully reflective of volume status. What you can see here is a fairly dilated IVC, and probably does not collapse more than 50%. So this is a patient with high right-sided pressure, and likely not somebody you would be giving a lot of volume to. Here's our parasternal long. So first, just in terms of assessing the quality of the image, I would say that there's a bit too much apex in this view, and the heart is a little bit too vertical. So the ideal ideal parasternal long is a more horizontal heart, and we really want to be focused on this part of the heart so we can see the leaflets of both the valves very clearly, as well as that ascending aorta. Nevertheless, we can make some assumptions from this view. So look, if you go back and look at the normal heart, you will see that this RV here is rather large. And the other thing that you will note is that this mitral valve is not opening as well as you would see when you look at the images of the normal heart, which does imply that there's some degrees of decreased cardiac output. And to be fair, this whole ventricle looks tiny little bit hypokinetic in this view. The aortic leaflets are not 100% clear, but you do get the impression that there's some opening and that the leaflets are not thickened, and we don't get that sense of calcified echo dropout that you would get with a very calcified aortic stenosis, so likely a normal aortic valve there. So this is our parasternal short axis, a little bit mitral. you probably do want to try and get a little bit more midpapillary to get your best to get a good midpapillary view, so the basal. But what we can definitely clearly see is the flattening of the septum here, which does imply some ventricular interdependence. And you have to be really careful here to not volume overload that RV, or it will start affecting the ability of your RV to function. Here's our apical 4. So on a normal apical 4, what we want to really see is that LV being dominant in the apex with a nice perpendicular septum. Now the reason this image is not giving you that is not because there was bad image acquisition, but because the RV is so large. You can see that this RV, which usually we would say should be about a third of the LV, and if you look back at the RV lecture, it's usually more of a triangular shape. This is a very kind of dilated and large RV, larger than the RV, and the RA is very, very big as well. You can see your mitral valve here opening well. I would say that this LV, from what we can see, we're not seeing endocardium 100% clearly, but what I can see, I don't think that LV is contracting normally. This is a more RV-centered view, and really good look at this base as well as the free wall. And doing a TAPSE through there, it's not measured, but I'm almost 100% sure that if you do the measurement, it's going to be less than 16 millimeters, so decreased RV function. So then what would your opinion be? What information would you give through to the anesthesiologist that's going to be doing this case? So this would be my information. I would say there's a severely dilated RV with a D-shaped septum, decreased RV function because of the decreased TAPSE, although the free wall is still contracting fairly well, and also some left ventricular dysfunction. And these are probably pieces of information that I think you can agree will be very helpful to an anesthesiologist going in doing potentially quite demanding case for the patient's cardiorespiratory system, doing jet ventilation with potential hypoxia, CO2 retention, and clearly requiring some kind of hemodynamic support to tolerate those respiratory variations. Okay, thank you for watching. See you soon.